All right. Hi, everyone. Thank you for joining us this evening. This evening's talk will be given by Dr. Alex Vaccaro, our spine surgeon and president of Rothman Orthopaedics. He has a great informative talk on lumbar disc herniation tonight. If you have any questions throughout the presentation, please feel free to enter them at the bottom of your screen in the Q&A box, and Dr. Vaccaro will take time at the end to answer as many as he can. Dr. Vaccaro, you can take it from here.
Thanks, Natalie. It's an honor to be able to sit here and speak. I really enjoy doing this, and I've chosen every quarter a topic that seems simple, but it's actually very complex because I'm going to take you through the history of a problem, how to think about it, how to diagnose it, how to treat it, and then what the new innovations in treatment are. Every topic is very simple. It's not going to be anything esoteric like AI understanding of large data sets. This will be about lumbar disc herniations, which we all suffer from. So to keep things in perspective, patients come to me all the time, family members come to me all the time and say, I feel miserable, I have horrible back pain, and I tell everyone, don't worry about it. All of us at one time will have significant back pain. I could think of two or three times when I thought I was going to die because I moved the wrong way and I fell to the ground and I was there for a few hours. I was like, oh my God, I feel miserable. So 80% of us will have an episode where we feel horrible. And some of us, it goes on to chronic discomfort. And we focus on, improving our flexibility or range of motion or core. And then a much smaller percentage of us will actually herniate a disc. And between each vertebral body, if you look at the screen right now, you have a plain X-ray where the person is crooked, and they're crooked because they have a disc herniation. And disc herniation is irritating a nerve. So, and it depends on where that nerve is in relationship to a nerve, because sometimes you actually bend in the direction of the disc herniation, and sometimes you bend away from the disc herniation, depending on where it's located in relationship to the nerve and the axilla of the nerve and so forth. So disc herniations, they occur in about 2% of all of us. And they can be miserable. And the problem with the disc herniation, it can cause significant low back, leg pain. Now, who's at risk? Well, I'm just going to say I've seen a disc herniation in every type of background. I've had patients who have done nothing. I've had athletes get them. I've had patients that are not athletes. I've had people sitting at a desk all day long and they have a disc herniation. But if you look at all the risk factors in the literature, there's certain things that can contribute. If you load the spine and expose it to torsional stresses, just like a golfer, a tennis player. They have a high incidence of disc herniations. Football players bent down, twisting their back. More common between age 30 and age 50. But if you have a job where you're driving a truck, driving a bus, in the car all the time, those patients can get disc herniations. There's certain vibrational loads that can exacerbate. So when I do spine surgery, I always tell every patient for the first 30 days after spine surgery, try to avoid a car. If you have to use a car to go to work, use a car to go to work. But the vibration of a car makes people miserable. So these are the risk factors, just keep it in mind. But the bottom line, anyone can get a disc herniation. Now, we always have something called red flags. Like, when should you get nervous? So say tomorrow you wake up after this lecture because it's in your mind and you start getting back and leg pain. Don't panic. I see it all the time. Say if you get back and leg pain and you start getting weakness, then you got to be concerned. But there's something called a red flag when you really have to be concerned. And when the disc herniation is so large, it crushes the nerves after they leave the spinal cord at L1. So you call that the cauda equina. You can get cauda equina syndrome if a disc herniation is so large at L4, 5, and L5S1 that all of a sudden you can't initiate urination. All of a sudden you get numbness in the groin area. You may begin to develop early stages of urinary incontinence. If those symptoms develop, you go right to the emergency room. You don't waste time calling anybody. You go right to the emergency room because an MRI has to be performed in that setting. And if you see a large space occupying lesion, it's in your best interest to have that removed within 48 hours. So the sooner the better. But if you have a massive space occupying lesion and you develop bowel and bladder dysfunction, perineal numbness, you got to move because that's a problem. So that's a red flag. And we have other red flags, like people come to me, when should I get an X-ray? Well, if there's trauma, if there's a risk of infection above a certain age, You got to get an X-ray. But those symptoms, that's a red flag for cauda equina syndrome. Now, the next question people always ask me, do I have a disc herniation? Do I have a bulging disc? Do I have a protruded? I mean, and there's a very scientific definition for each one. A bulging disc means the anatomy's intact. When I stand up and sit down or lie down, there's changes in my spine. I can have a bulging disc, and then when I lie down, the bulging disc can go away. That's common. So bulging disc, we see them all the time. Don't be worried. A protruded disc means part of the disc material, the nucleus pulsus, is coming out, but the lining's intact. What you have is you have the nucleus pulsus, which is the disc itself, and then you have the annular fibrosis, which is the membrane around. So protruded disc means some of the disc is coming out, but the membrane's intact, so it's protruded. Then you have an extrusion where it actually leaves, and you can see there, it leaves the disc circumference, the annulus fibrosis, and then it gets stopped by another structure called the posterior longitudinal ligament. So if it's stopped by the posterior longitudinal ligament, which is another ligament, then it's called a subligamentous extrusion, means it left the disc space, but it's protected by the PLL, the posterior longitudinal ligament. Or it can get away from that posterior longitudinal ligament, and now it's free floating in the canal, and that's called an extraligamentous extrusion. And the disc can go in different directions. It can go through a vertebral body, that's called the limbus vertebrae. It can go out the front of the spine and make contact with the vessels. It can go backwards into the spinal cord, into the nerve roots. So we say it's a posterior, it can go lateral. We have a designation, but the most common that we see on posterolateral disc herniations, they come out on the side. That's the most common. So when they come out on the side, they usually get what they call the traversing nerve root. Now, what does that mean, traversing nerve root? If you look at this picture that you probably won't understand, nerve roots come down and they go out what they call an exit passageway called the foramen. And that's right below a piece of bone called the pedicle. So when it goes out that's the exiting nerve root. And then the next nerve root goes by that and goes below the next pedicle. If it's a posterolateral disc herniation, it doesn't hit the exiting nerve root, it hits the one going below it. So L45 disc herniation always gets the L5 nerve root. It's one of our questions in our test. L45 always get L5. Now, if it's at the disc level, but it's really far lateral, it's going to hit the exiting nerve root. So an L45 lateral disc herniation will get the L4 nerve root. So that's just something we do. So I can tell when I see somebody and they have pain, if they have pain in the front of the thigh, I know it's one of the femoral nerves. If it's pain in the back of the thigh on the side, I know it's a sciatic nerve. And I can tell the L45 goes to the big toe. The L34 will go to the knee. So I could just talk to a patient. If it's in the back of the calf, side of the foot, it's got to be S1. So you know as a spine surgeon, just by the anatomy, and we tell all of our residents and fellows, study anatomy. Anatomy is the key to surgery. Know the anatomy know the anatomy cold. You got to know it, know it, know it. Study it every day. Go to as many cadaver labs as you can. Know the anatomy. So when someone comes to you and gives you a verbal description of their symptoms, you can usually make the diagnosis without looking at an advanced imaging studies. Now, the fortunate thing about a disc herniation, I tell this to everybody, never jump into an operating room unless you've got weakness or cauda equina syndrome. If you're miserable pain, try to suck it up, anti-inflammatory stretching, try to go at least 6 weeks without surgery because you could get better. And the vast majority of patients get better within the first 30 days. So now, if someone has weakness, they may not want to wait. If someone has cauda equina syndrome, you can't wait. So I understand that because getting strength back is unpredictable. But if someone doesn't have weakness, if they have just that pain, no matter how miserable you are, if you can suck it up, if you can, rest, anti-inflammatory medication, stretching, and then get up and move very gently, because the vast majority get better. And if you look at the size of a disc herniation, here's the paradox. The larger the disc herniation, the more likely it can resorb because of the vascular tree and it's exposed to all the vessels. So larger disc herniations may have a component of hemorrhage. They can resorb. Now, the corollary is the larger the disc herniation, if you don't get better, they tend to go to surgery more often. They tend to do great with surgical intervention, more so than smaller disc herniations. But depending on the size of the disc, there's a chance that it can resorb over time. So keep that in the back of your mind. So if you look at this, there's two classic studies that we look at when we teach our residents and fellows on the natural history of a disc herniation. The Weber study from Scandinavia confuses a lot of people because when I first was educated in this, I was educated, oh, if you could suck it up at 4 years and at 10 years, if you had surgery, didn't have surgery, you did this, you did the same. So it's like, well, if you do the same, why not have surgery? But then when you actually read the paper, you find out that of the 280 patients, 67 went right to surgery. So automatically it's not a natural history study. And then the other group of patients that did not improve were randomized, and the randomized group did better with surgery. And this question was sort of answered with what we call the SPORT trial. This was one of the largest studies that we participated in at Thomas Jefferson and the Rothman Institute, where we had 501 patients randomized to non-operative, operative, or observation. Some patients just said, I don't want to be in a randomization protocol. I want to be observed. So what came out of it was the entire group of patients, if you had surgery, you did great. Now, if you're into epidemiology and you're into doing research studies, you have the intent to treat group and you have the as treated group in any type of study. So if I randomize you to non-operative, but then you cross over to surgery, you still get counted as part of the non-operative group. If you look at the intent to treat group, they did about equal. But if you look as the as treated groups, the surgical group did so much better. So I tell patients, if you have that disc herniation out, you have an 85% chance or better of saying thank you. I feel great. And a surgeon should never say higher than 85% because you could do a perfect operation in a perfect patient with a perfect symptom, since patients still may have symptoms. So if a surgeon says the chances of you getting better are 85% or more, that's a great prognosis. If a surgeon says to you, it is about a 60% chance, that means don't have surgery. 60% chance is, it's like a placebo effect. 85% or better is perfect. So keep that in your mind. And as I said before, there's a paradox. The larger the disc, those tend to go to surgery more frequently because people are miserable. And when you do surgery on those larger discs, they tend to do better. When you see someone having surgery for a bulging disc or protruded disc, the outcome isn't as great. So if you want to hit a home run, you want to have an extruded disc fragment that's large, and that patient is going to do great with surgery. And you could be more aggressive with non-operative care if the surgical fragment is smaller. But I always tell people, wait at least 6 weeks. Now, other people say, well, how long should I wait? When is it too late? Older studies have shown that if you wait more than 6 months, the outcomes from surgery aren't as great. You still do well, but they're not as great. So keep that in the back of your mind. Now, I'll get into the surgery. I won't get into the gory details, and I won't show any videos to make people puke on the telephone, on the video. But the goals of the procedure, if you do any surgery, no matter what technique you do, you want to take off the pressure on the nerve, and you want to do it in a minimally invasive fashion so you don't cause instability. So you teach every resident fellow, take the pressure off the nerve and don't cause instability. Now, people say, well, is scarring a problem? And ever since I was a young resident, people thought scarring was a problem, and people came up with chemicals to decrease scarring. And we just have not been able to prove that scarring is actually a problem. Some believe it is. Who knows? And I just want to make it perfectly clear to you, no matter what procedure I do with an endoscope, a tube, mini open, you're going to have scarring. There's no such thing as no scarring. And the vast majority of patients don't have problems. So who knows what the answer is, but we can't prove that scarring is a problem. And when patients sit down and say, well, what are the complications from having spine surgery? And they're small. You have a less than 1% chance of having a nerve injury, having a spinal fluid leak. The thing that I tell patients is that up to 7% of patients on a primary disc may in the future have another disc herniation at the same level because we only remove the fragment. We don't take out the whole disc because it's not in the patient's best interest. They need that shock absorber. So we take out the fragment. So 7% chance of reherniation is something that I tell people. So the little techniques that I like to use, and I'll go through this little picture. Number one, when we expose the interspace, and this is assuming the patient doesn't have any skin or anything, is that you come down between the two lamina, you have this structure called the ligamentum flavum. It's just a membrane between one lamina and the other, so you take it down. Once you take it down, you're looking, the next thing a surgeon does is they feel for the bony pedicles I told you before, because I know right above the pedicle is the disc. So this, I feel right away, minimally invasively for the pedicle. I know the traversing nerve root is medial to that. I know that underneath that traversing nerve root is a disc fragment. So I feel the pedicle. I put my instrument underneath the nerve and I gently move it over. So you can see the nerve there. You move it over, and then you see the disc herniation. And what usually happens, it's like popping a zit when you're in high school. It just like pops out. Like the disc just pops out. And it's such a gratifying feeling because you know that patient, when they wake up, is going to feel great. So that's what you want to do. So you do not take the entire disc out. You just take the fragment out and you make sure there's no other fragments around because the patient needs their disc, and that's why you want to do it minimally invasively. And then you irrigate it to remove any inflammatory cytokines. And then you make sure there's no bleeding because you don't want the patient to develop hematoma. And the blood products can cause inflammation. So you make sure you irrigate, no blood loss, and then you go ahead and you close. And my little trick I do is I sort of take down that ligamentum flavum, I raise it up, I do the work, and then I let the ligament flavum come down because that stops any blood from entering the space that may decrease the amount of fibrosis or scarring. So that's a little trick you do in that situation. These cases are all same day surgeries. Once you remove it, the patient comes out of the operating room. The patient should say, I feel great. My back is killing me. I feel great. My leg pain is gone. My back is killing me. And then you give them medication they need for a few days for their back discomfort, and they go home. And everyone has a, I inject the wound with an anesthetic. I get them up. I don't like to put steroids on the nerve itself because I don't like steroids in general within the wound because I think it sort of decreases any type of immunologic response. I think it may increase the risk of infection. But if you do a nice, smooth operation with minimal manipulation of neural elements, patients feel great. Now, people say, what technique do you use? We have tried every technique. So what happens is in my operating room, I have tools that we have developed over time that I use so I could do it in my minimally invasive fashion. But any technique, and if you look at the natural history, as long as you do a wonderful job in taking the pressure off and do minimal manipulation of neural elements, all the techniques, final outcomes are equal. So you may want to use an endoscope, you may want to use a tube, you may want to use an expandable tube, you may want to use a talar retractor. It doesn't matter because if you look at all the long-term results, now the smaller the incision, it most likely theoretically decreases the risk of infection, but infection is so low, like I showed you before. So it's so low, but it's less tissue dissection, less discomfort after surgery. So each technique, and this is just an example you see of using a tube. You put a trocar down, the tubes expand to about, you can go up to 18 millimeters, 22 millimeters, and or you could take a scalpel and make the same size incision with another tool that goes down and levers, and it allows you to see in and take the disc out. So if you look at both techniques, a traditional microdiscectomy is only a little bit bigger, but you can make the skin incisions really small, and you can use your retractor to make it bigger. And if you look at the outcomes from minimally invasive and open, minimally invasive, less dissection, less tissue discomfort, quicker ambulation. But nowadays, I don't know anybody who's not sending their patients home 2 hours, 2 to 3 hours after surgery, because this procedure should take you very little time compared to the more complex spinal operations. And we're at the point now where we're exploring all types of new innovative techniques of doing it using endoscopes. Now, when I was training in the 1980s, I always give credit to a guy by the name of Parvis Kanban. Parvis Kanban taught me how to use an endoscope. And that concept came around in the 1930s. The technology wasn't really advanced in the 70s. But when I was a resident in the late 1980s, scoping became common, and Parvis Kanban came up with the Kanban triangle. So it's right where the exiting nerve comes out. Right below that, there's a triangle. You could say the pars, which is the lateral portion of the supraarticular process in the bone, is the medial border. The nerve is the oblique portion of the triangle, and the floor is the pedicle. And that's a triangle. So you can dock a scope in that area, and that's where you would see a far lateral disc, or it'll allow you to get into the canal. So there's different ways of doing it. So Kanban came up with many different ways of doing it. This is an example. The APLD was the automated percutaneous lumbar discectomy. Literally, you would go in and you remove the disc, and then Tony Young, who I was friends with, I think he's retired now, he developed scopes to do it. But now, and if you look at the literature, back in the day, there was hardly anything written, and now there's a plethora of articles being written about endoscopic surgery. So now, if you look closely, you can do full endoscopy where you have an endoscope that has a light source, that has a camera, that has irrigation, and then it has a channel for the tube. Or you can do two scopes, one that is an actual scope to look at, and the other is an actual working portal. So full endoscope, one thing, put it down, look around, do what you have to do. A lot of these systems have water that sort of expands the field so you can look at an aqueous environment, or you could do two scopes. And then not only can you look at it right directly, you have other techniques where they go into the disc space itself. So you have some surgeons doing, when I was younger, it was called the upstairs technique and the downstairs technique. Now you have endoscopy where you could put a camera in, you could put a scope in, and you could do a laminectomy. Or you have others that do biportal where they put one in the disc on one side, one in the disc on the other, and they take the disc out from the inside. So there's so many techniques that we've used to take the disc out. So who's going to get better? Because I know you guys are anxious to ask questions. Um, if you operate on someone that has primarily leg pain, that patient's going to do great. What percentage of patients' back pain gets better with this procedure? Well, remember, it's not a back pain procedure, but I say 50% of the time someone's back pain may feel better, and I have no idea why. If the pain is truly in the sciatic distribution, you're going to do great. If it's buttock pain, If it's buttock and proximal thigh pain, But if it goes below the knee, calf, and you're doing an L4-5 and L5S1, that person's going to do well. If it's a large disc herniation, they're going to do well. And again, don't wait too long. After 6 months, they do get better, but not as great as they can be if they're done within 6 months. So the goal now is minimize as much tissue dissection as you can do. Focus on those with leg pain. Try to give them a trial of non-operative care. If they can't tolerate the pain, then you do surgery. Keep an eye out for the red flags like cauda equina syndrome. You don't want to miss that. Someone tells you they have numbness in the groin, you're getting an MRI, you're going to the emergency room, and you're dealing with that depending on what it shows. So, and then I take care of all the athletes and professional teams around here for their discectomies. You can get most people back to play sports within 3 months. I tell golfers don't swing an iron for 5 months, but you could do the short game at 6 to 8 weeks. But you increase the torque of your back 8 times by swinging a golf club. And who does miserable with spine surgery? Golfers. So be careful with golfers, as you know. So thank you very much. And now I'll open it up to any questions.
Warranted. And is it similar to a microdiscectomy?
The only time you need to do a hemilaminectomy is if the disc fragment comes out of the space and extrudes in a cephalad, which means upper direction, and it's behind the body. So if you just enter the disc space with your endoscope, you're going to miss it. So you need to take out that hemilaminectomy. That's the only time you need to do that. And if you don't do that, you're going to miss the fragment and the patient's going to be miserable. Well, it can be. The surgeon, I'm sure, made sure there was no more pressure on the neural elements, and you can have inflammation. So see how it goes. Now, if your leg pain never gets better and you're miserable, then you have to call the surgeon and say, listen, it's been a week or 2 weeks and I still have leg pain. And then he's got to investigate why that happened. Now, when you get an MRI scan right after surgery, the blood products can be confusing because they cause an image artifact. So sometimes it could look like you still have a disc herniation when in reality you don't. So it's really confusion. But if you feel better, but you still have spasms, you're going to do okay. It'll settle down. It'll settle down. But if you still have the same exact pain 1 to 2 weeks after, you have to have that investigated.
Next question. Does it make a difference with walking every day, drinking more water, or anything to suggest for disc herniation besides physical therapy?
Well, walking is like 85% of the world's method of physical therapy. So if you tell me you're walking every day, you are doing physical therapy. I mean, I'm not that aggressive with physical therapy. Walking is great. Walking on elliptical is great. Doing a stationary bicycle with your back straight is great. Not the Peloton where you're bent over. If you can progress to an elliptical, that's great. water activities are great. Walking is fantastic. You're doing it, and I love drinking water. Stay away from the bourbon. Okay, you got to be careful because if you do a decompression in the setting of instability, you may cause the instability to worsen. So you got to be careful. So just think about it. So I have done discectomies instead of scoliosis, but I carefully look at the segment, and sometimes it may warrant fusing the segment you do the discectomy to prevent the scoliosis from progressing. So if your surgeon thinks it's a stable scoliosis, you could do a discectomy. If it's at the level of a rotatory subluxation or spondylolisthesis, means you got to be very careful because you can feel good for about 9 months and then you're going to get miserable because the instability is going to progress. So your surgeon has to tell you, yes, I believe that's stable, and I'm just going to do a minimally invasive removal of the fragment.
Thank you. How long can you get toe numbness after surgery?
Okay, so when someone comes to me before surgery and they have numbness, the literature says that 50% of the time the numbness will get better. 50% of the time, which means the other 50% won't get better. Now, say you didn't have numbness before surgery and you just had pain. I've had patients that when you take their pain away, they feel numbness. And I'm always confused. I wonder if the numbness was there, but it was overshadowed by the pain. So that could be a reason for the numbness. And again, 50% of the time that'll get better. If you didn't have numbness at all and you had numbness after surgery, that's because the disc herniation was probably so large, the surgeon had to really mobilize the nerve and there's a lot of inflammation. And that should settle down if you didn't have it before surgery, and that should over time get better. But the golden rule is this: 50% of the time it goes away. The other 50%, a year out, patients don't notice it as much.
Thank you. How about a type of mattress? Any recommendations on mattress types for back pain?
Firm orthopedic mattress. Don't have one of those where you fall and you disappear in the bed. Super rigid, I don't like. You just want to have they call a firm orthopedic mattress. And I don't know I mean, every time I buy a mattress, that's what I ask for. And I feel great because I tell you, when I started to take a statin for my high cholesterol. I was miserable with back pain. And I got a firm orthopedic mattress, which helps me. And that back pain lasted like 6 months. So that's what I do. And if you have a disc herniation and you're using a flat, firm orthopedic mattress, you want to take the tension off the nerve. So it's good to put like a pillow under your knee to flex the hip. So you take the tension off the nerve. That'll make you feel better when you have a disc herniation.
Great. If you have a herniated disc and do not have surgery, will you have lifelong back issues?
No, if it gets better, you won't. Remember, I told you that the vast majority get better. I say the vast majority of people who do not have surgery, 90% will eventually get better. 10% may have issues if they have a large enough disc. You just have to be careful because if you have a weakness like a foot drop, you don't want to be too nervous to have surgery that you can't do the activities you want, where you can't dorsiflex your foot. So if the pain gets better and if it doesn't, I mean, what's the only reason to have surgery is so you can get back into your quality of life better. So like, why suffer? Like, I'm a perfect example of someone who suffers. I have really bad knee arthritis, but it doesn't hurt me when I operate. So I don't jog anymore. If I was walking across the street and a car was about to hit me, I'd be like, okay, let the car hit me. Because if I jogged, I'd be miserable. So I'm like one of those guys that are not listening to my own advice because I should have my knee done, but I'm too busy, so I'm not going to do it. I tell the same things to someone with a disc herniation. How long do you want to be miserable? Most people don't want to be miserable for more than 6 weeks to 3 months. Then I'd probably have it done.
Thank you. What percentage of repeat surgery? If someone already had a lower lumbar microdiscectomy surgery, what percentage of those patients end up needing another surgery?
7% of people can herniate a disc if they have a discectomy. It doesn't mean they're going to have surgery for it. Now, but if you look at natural history studies, and I'm always researching it, someone who has a discectomy, for whatever reason, has a 14% chance, and this paper just came out, of going back to the operating room again for some of it could be related to that disc, it could be spinal stenosis. But remember, there's a genetic overlay. Like, why do people have spinal stenosis? Why do people have spinal listhesis? Why do people have scoliosis? There's got to be a genetic predisposition plus an environmental. So if you have spine surgery, 14% of people will eventually have another procedure in the future. Well, I'm going to tell you one thing. Spinal stenosis is different than a disc herniation. But remember, spinal stenosis is a general term. Anything that narrows the space is stenosis. So a disc herniation can cause stenosis. But my next lecture in the next quarter is going to be on lumbar spinal stenosis, which is a big topic. So my first lecture was on cervical disc herniations. This one's on lumbar disc herniations. My next lecture will be all on lumbar spinal stenosis, and we'll get that announcement out.
You mentioned groin pain. Please describe. Pain upon movement from the inside of my leg near the groin area.
So the number one reason for groin pain is hip arthritis, acetabulolabral tear. It could be a hernia. It could be a kidney stone. It could be, and that's why people have hip pain. I'm talking about you're getting numbness, like a weird numbness where you touch your groin and you're like, it feels weird. That with leg pain is a problem. That's a problem. And you have to have that evaluated.
Quarterly injections. When are they helpful? This specific question is, when is it helpful for an L4 L5 large disc perfusion with significant effect upon the left L4 nerve root?
So if you look at the science, all the controlled prospective randomized studies, you have a 60 to 70% chance of having pain relief with an injection. If you have weakness, an injection is not going to help weakness at all. It just decreases inflammation. So if you plan not to have surgery and the surgeon doesn't think the space occupying lesion is so big that the extra fluid is going to cause more compression, which could push you into cauda equina syndrome, then epidural steroids is an option because it may make you feel better. And some will have 1, 2, 3 over a certain period of time. But the mechanism basically is decreasing inflammation.
Yeah. To travel in 6 weeks, a 9-hour flight, a lot of walking around, driving on a bus. And I just had surgery on Monday. Would it be smart for me to travel?
Oh yeah, I operate on people routinely who fly out the next day and sometimes that night. They fly in, have surgery. The most important thing was in the first 6 weeks to 3 months of surgery, you have an increased risk of getting a clot after you have general anesthesia. So you have to be on oral aspirin or sub-Q heparin. And when I operate, I'm operating on people tomorrow that will fly out and they will get sub-Q heparin and they'll stick it in their butt before they get on the airplane. So so within 3 months of surgery, you got to get yourself on 81 milligrams twice a day of aspirin if you can take it.
Yeah. What is your opinion on spinal fusions?
Well, I only am an advocate of spinal fusions if you have a deformity, tumor, infection, trauma, or instability. If you do fusions for back pain, it has a 50 to 70% success rate. So fusion is great when you need it. Don't be afraid of it. It's like anything else. It's like the debate we see in politics, like the Democrats hate the Republicans. Oh my God. Fusions are great when fusions are indicated. You just have to understand what the indications are. Don't be afraid of a fusion because if you need it, it's the best thing you can do. If you don't need it, you definitely do not want to have it.
Yeah. In a physical workplace environment, what general steps or procedures would you recommend to reduce the overall impact on lower back injuries?
You want to have a standing desk. You want to get up and walk. You want to walk and stand, and you will decrease the amount of morbidity related to most workplace low back discomfort. And I'm talking about a non-labor position. In a labor position, you have to understand the ergonomics of lifting, carrying things, keeping yourself conditioned. But for the vast majority of us, make sure you're walking around with your back straight. Get a standing desk if you can. change your position. Do not be a couch potato in your office.
Yeah. We may talk a little bit about physical therapy, but there's a couple of questions asking if it can help with back pain or disc herniation, either pre or post-operative.
I love physical therapy pre-op. I love physical therapy post-op. I know it can be expensive, so when you go, you want to learn what you need to do. You want to figure out everything you can do on your own so you don't have to continue to go to it. Because going to it is a pain, but you want to learn all the basics on core strengthening, range of motion, flexibility, and strengthening. I'm a big advocate, and it should be lifelong. After you have surgery, it should be something you do every day.
How does grade 1 to spinal fasciitis affect lumbar spine and disc herniation? Does it cause weakness when walking?
Okay, now you're jumping into my talk. Now I'm gonna have spinal stenosis in 3 months, and then after that I'm gonna do spinal grade 1, grade 2. So grade 1 spinal means 25% slippage. Grade 2 means 50% slippage, and it can cause significant leg pain because it entraps in what they call the lateral recess or subarticular zone, the traversing nerve root, and you could be miserable. But stay tuned for the answer to how to manage that at the next lecture. Okay, so Natalie says goodbye. She loves everybody. And tomorrow, Nat, let's talk about what went up. What, this happened before, by the way, a while ago. So let's try to figure out what went wrong, okay? Okay, so if you have any questions, reach out to Natalie. We have her email address, and we apologize for the technical difficulties, and we'll figure it out by tomorrow. Thanks, everybody. Have a nice day. Bye-bye.